This video is about tracheostomy. It is an opening surgically created through the neck into the trachea to allow direct access to the breathing tube. The indications for tracheostomy are area obstruction, as a respiratory support, pulmonary hygiene, to eliminate dead space, and treatment of obstructive apnea. Before tracheostomy, a preoperative evaluation should be done to check for the level of obstruction, anatomy of the neck to check for difficulty of tracheostomy, coagulopathies should be corrected prior to tracheostomy, check for the cardiorespiratory status, and check for deviation of the trachea. So now let's proceed to the procedures. A tracheostomy should be done under local anesthesia. Next is to position the patient. Place the patient in a supine position with the neck extended with a pillow or bag under the shoulders. For the surface landmarks, identify the structures of the neck, starting from the inferior notch inferiorly, cricoid cartilage, and the thyroid notch. Sterilize the skin of the anterior neck and chest and drape the neck. Make a horizontal incision 1 finger breadth below the cricoid prominence. Extend the incision through the skin and subcutaneous tissue and dissect towards the trachea by parting the tissues with scissors, remaining strictly in the midline in the vertical plane to avoid injury of the inferior thyroid veins. Identify the midline cervical fascial plane between the steroid muscles and divide the intermuscular plane by dividing with a pair of scissors and retract the muscles laterally. Retract the thyroid isthmus superiorly if it is visible to expose the trachea. Expose the infrathyroid trachea by carefully parting the overlying soft tissues by a pair of scissors. Ensure that the surgical field is completely dry before proceeding. To confirm the location of the trachea, aspirate air by a needle attached to a syringe. There should be the presence of bubbles. In an awake patient, inject lidocaine in the trachea prior to insertion to prevent coughing. Create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. Suture the anterior tracheal flap to loosely secure it into the skin. Assess the size of the trachea and select the largest cuff tracheostomy tube that will fit the patient comfortably. Insert the tracheostomy tube with introducer into the tracheostomy while applying traction to the silk traction suture attached to the tracheal flap. Remove the introducer once the tube is inserted into the tracheal lumen. Place the inner cannula and inflate the cuff. Attach the anesthetic tubing and ventilate the patient while correct placement of the tube within the trachea is confirmed by checking the expired carbon dioxide, checking for the chest movements, and listening to the breath sounds. Secure the placement of the tracheostomy tube. Tie them with the neck flexed. The ties should be tight enough and no more than a single finger under the tape. The early complications of tracheostomy are bleeding, pneumothorax, pneumomediastinum, subcutaneous emphysema, damage to the esophagus, recurrent laryngeal nerve injury, and airway fire. Late complications are accidental recannulation, infection in the trachea and around the tracheostomy tube. Trachea may be damaged by pressure from the tube, friction from the tube that moves too much, and bacteria that cause infection and form scar tissue. Thank you for watching.